So I had a pediatric patient come in the other day to get an MRI and needed anesthesia to get through the case. And the patient had Williams syndrome. And as soon as I said Williams syndrome out loud, all the pediatric anesthesiologists in the room gasped. Listen along if you want to hear why. So Williams syndrome is a neurocognitive developmental delay that happens because of a genetic defect on chromosome 7. But the thing that we really care about as anesthesiologists is the cardiac defects that come along with it. So the biggest problem for us as anesthesiologists is that these patients have supravalvular aortic stenosis. This aortic stenosis basically acts as a fixed obstruction outside of the heart. And so if there's any drop in systemic vascular resistance, these patients are going to get hypoperfusion. So up to 70% of patients with Williams syndrome will have supravalvular aortic stenosis. They can also have some degree of pulmonary artery stenosis, as well as different abnormalities with their coronary arteries. The case reports that you'll see is that these patients will just die spontaneously on induction in the operating room. The biggest reasons for these cardiac events is because these patients undergo inhaled induction just like you would for any sort of pediatric patient with a high percentage of sevoflurane. But when you have someone breathing a high percentage of sevoflurane, that causes massive vasodilation, which in this case causes a decrease in systemic vascular resistance, which becomes a problem when you have a fixed obstruction outside of the heart, like the supravalvular aortic stenosis. This drop in systemic vascular resistance will lead to a drop in the perfusion through the coronaries, which then will cause a snowball effect where the myocardium is not getting perfused, causing basically hemodynamic collapse. The best way to treat these patients when you know that they have Williams syndrome and if you're concerned about supravalvular aortic stenosis is to make sure they're well hydrated. So typically these patients can be NPO from fluids 2 hours before their surgeries. So you want to make sure that they're hydrating up to that point. You also can give them IV fluids to make sure they're not dehydrated upon induction. Also, if you can avoid using high sevoflurane or high percentages of sevoflurane during your induction, like doing an awake IV, that would be very helpful in the situation as well. The other way you can combat the drop in systemic vascular resistance is by using a pressor like phenylephrine, which will increase that systemic vascular resistance and basically counteract the anesthetic effects. In our patient scenario, she actually underwent cardiac surgery and had the stenosis repaired already, and she had a recent echo which showed normal sizes for her aortic arch as well as her ascending and descending aorta. So we really didn't have too much to worry about in terms of her induction. We still did an awake IV on her and maintained a normal blood pressure throughout the entire anesthetic. This is just another example that as anesthesiologists, we deal with different syndromes through pediatrics and adults, and you have to do your due diligence to do some homework before they come to the operating room so that you know their complete history and that you can provide the proper anesthetic care to make sure everything goes smoothly the day of their procedure.